Hello, I'm Matt Galloway, and this is the Current Podcast.
It's going to get worse. That is the message from the World Health Organization about the Ebola outbreak in the Democratic Republic of Congo. It involves a particular strain of the virus with no cure and no vaccine to prevent it. And the outbreak is growing fast. According to the WHO, there are now more than 900 suspected cases and more than 220 people are dead. Yesterday, Canada introduced temporary border measures in response to the Ebola outbreak. Travellers from affected regions will be required to self-isolate for 21 days, and immigration documents from the DRC, Uganda, and South Sudan are temporarily suspended. Dr. Craig Spencer is an emergency physician, public health researcher, and professor at Brown University in Rhode Island. He treated Ebola patients in West Africa in 2014 and 2015 during the largest Ebola outbreak in history. Over 28,000 people contracted the virus in that outbreak, and he was one of them. Dr. Spencer, good morning.
Good morning.
What goes through your mind when you hear the numbers in this current outbreak?
The first day that I heard about this outbreak, really the first moment that I learned about it just over a week ago, I knew this was going to be catastrophic. And I knew that because the number of cases that were being reported on day one were over 200. The size of the outbreak at first report was bigger than most Ebola outbreaks are when they end.
Ooh.
And on the same day that we heard about this outbreak in DR Congo, there was confirmation of another case hundreds of kilometers away in Kampala, the capital and most populous city in Uganda. So you know already that not only do you have a lot of cases, but they're spread over a large region already, just as you're starting to learn about it. This is bad when you've already got people on the ground and already starting to respond. But if this is what you're learning when you first learn about it, you know this is going to be trouble.
Worse, you think, than the outbreak that you were dealing with in 2014 and 2015?
I worry that there's certainly that potential. I would say right now, we think there's we've been told there's around 1,000 cases in eastern Congo, Uganda, and in the region. I suspect the true number is probably double that. Because if you look at what's happening on the ground, many places haven't been reached yet. We don't have a full accounting of how many people have actually been infected over the past few months. This has been going on for a while. We don't have the testing that we need. There's a backlog of samples that need to be run still to be confirmed, and we don't have good knowledge about the transmission chains, meaning who has infected who, how those people are all related, and whether they're related or not. And my suspicion is that we just have a bunch of tattered ends here that we haven't started to pull together completely yet, and I don't think we're going to get a good idea what this truly looks like for another week or two.
You were in Guinea in 2014 during the largest Ebola outbreak to date. What was it like treating patients at that time?
Oh man, it was tough. It was really, really hard. I know, there's probably people listening now who were there and will probably feel triggered. But, as a provider, trying to take care of folks and still having half of your patients die despite everything you did for them is like the worst thing that you could imagine as a healthcare provider. And, you'd go in the morning and talk to patients that looked okay, and then you'd come back in the afternoon and they'd be dead. You learned really quickly that anyone really young or anyone kind of old probably wasn't going to make it. And you learned things that like hiccups were an incredibly ominous sign. It wasn't the bleeding profusely from organs that you hear about in books or on social media that I was worried about. It was things like hiccups that portended a really bad outcome. And all those things still stick with me a decade later, as do the thoughts and the stories of all the people that I worked with, including many of the people that unfortunately didn't make it.
Is it hard, even now, to talk about it?
It's hard. The past week has felt helpful in a sense in that I feel impactful, and then I can talk about what we need and try to highlight the issues on the ground. I've worked in Eastern Congo for a long time. I know the region well. I know the challenges well. And I also know that what we need now is not, a conversation on, what the U.S. needs to be doing at home, as opposed to the real conversation we need to be talking about is what impact can the global community have on the ground immediately, U.S., Canada, other countries with resources, with people. We need to get this under control quickly, not just because it could potentially be a threat to countries like our own, but because the human toll of this is just horrific and cruel and devastating, and we need to help end this as quickly as we possibly can.
I do want to talk about the measures that are being put in place, some of the questions around international aid, but I would like to ask you, if it's okay with you, about another part of your own personal experience, which is that you contracted Ebola at that time.
Yeah.
What was that like?
It was the worst 19 days of my life. There's no sugarcoating it. It was horrible. I wouldn't wish it on anybody, but I also, and it sounds strange, but I had the best case scenario of a worst case scenario, because unlike the patients that I was taking care of in Guinea, I had amazing access to high quality care in New York City where I was treated. I had probably 30 to 40 providers on call at any point to take care of me. And I was probably taking care of 30 to 40 patients at any point when I was in Guinea. So it was horrible, but I'm here today because of good, high quality care. I'm here because, quite frankly, I was treated in the United States, and I am forever grateful for that, but I'm forever reminded of that disparity between what I received and what I was able to provide.
You have written about how this is sometimes called a disease of compassion because of the way that it can make the people caring for the people sick. What are the challenges for healthcare workers on the ground right now, particularly since there's no vaccine and no cure for this strain?
The challenge for healthcare workers is, number one, there's just not enough of them. In 2014, there were about as many physicians on staff at the one hospital where I was treated in New York City as there were in Guinea, Liberia, and Sierra Leone combined. And 6 to 7% of all those physicians died of Ebola during that outbreak. It's a similar situation in Eastern Congo. Again, I've worked there a bunch, particularly over the past year, where there's been a lot of funding cuts. Healthcare providers have not only, lost their funding, but they've lost access to the personal protective equipment, or maybe even more practical and important things like gloves and other just basic necessities. And the second big issue is going to be that healthcare providers, there's not enough of them. They're also incredibly overworked, but they're the people, as you point out, that are the first line of defense. When anyone comes in sick, it's going to be a healthcare provider that jumps in to help, even if they don't have gloves, even if they're worried that this person may have malaria or pneumonia, or maybe even Ebola. These people are the folks that are going to help because they've been trained to help, but that puts them in harm's way and makes them extremely, extremely vulnerable to an outbreak like this.
It's not just the personal protective equipment, which is obviously a very important part of all of this, but you've suggested that the Trump cuts to USAID can be shown to directly affect our ability to track the disease, to be aware of the scale of the outbreak, to contain it. Can you talk about that?
Absolutely. I hear a lot of things about how AI is going to change the world. I talk to folks that tell me that it's going to be great for pandemic preparedness and picking up diseases early. But I remind them that working in Eastern Congo, I've been there before, and I've gone around and done surveys on health clinics, and half of the clinics may have already been empty. And now that number is going to be much higher. You need people in those places that can recognize the changes, that can raise red flags so that the rest of that county, the rest of that community, the rest of that country is aware and can alert the global community. Over the past year, we have pulled a bunch of logistical and financial support out of places like Eastern Congo. And that meant not just the loss of things like personal protective equipment, but also these disease outbreak and surveillance systems that the U.S. primarily has helped build over decades and the rest of the global community has supported. There has been a whole host of other things that we've also taken away that have had a dramatic impact on our ability not only to detect this, but to respond swiftly.
I do want to talk quickly about the measures that are being put in place. Canada just announced new measures yesterday, as I mentioned a moment ago. New border and screening measures for travelers from Ebola-affected regions. The U.S. has a travel ban in place for people from affected countries, including on U.S. permanent residents. How effective is that likely to be?
These are not likely to be effective. I call them political theater, and they're meant more for political points than they are for epidemiology. These are bipartisan, at least here in the U.S. These are things that happen every time there's an Ebola outbreak. I don't think they do much, but they're pretty standard. I will say the thing that has disturbed me the most, and what I learned yesterday, and I'm still finding hard to believe, is that the U.S. is setting up a program where any Americans with high-risk exposures are not being brought back to the U.S., where we have an incredible hospital system that is capable of quarantining and treating persons just like myself with Ebola. But the U.S. is now planning to construct a facility in Kenya where it's going to send high-risk exposures as well as treat Americans with Ebola. And it just blows my mind because we have spent the last year abdicating our traditional role as supporters and leaders in global health. And the U.S. is now abdicating its own responsibility to its own citizens. And I think it sets a horrible precedent. And I'm unbelievably concerned about so many things with this.
Well, listen, obviously a concerning time. We do appreciate you taking the time to put this into perspective for us. Thank you.
Thank you for having me on.
Dr. Craig Spencer is an emergency medicine physician, public health researcher, and associate professor of the Practice of Health Services Policy and Practice at Brown University. He was in Providence, Rhode Island.
This has been The Current Podcast. You can hear our show Monday to Friday on CBC Radio 1 at 8:30 a.m. in all time zones. You can also listen online at cbc.ca/thecurrent or on the CBC Listen app or wherever you get your podcasts. My name is Matt Galloway. Thanks for listening.